Oh, Kelly, I think you're.
I didn't even know I was leaving the voice message. That's funny. Okay. Yes, I'm trying. Not really, not really.
I think Kelly and I get to make the rules.
Yeah, that's right. There's no reason to sit back there. It's really chat on me. I was just coming from Manchester.
Yeah, of course.
And I said that. It was this huge 18-wheeler who had to back in and thread his truck off of Kelly Street into an alley. I couldn't, and he did it in one swoop.
Oh, some of those guys are amazing.
It was, and I mean, I'm telling you, he did not have 6 inches on either side of that truck.
Yeah, I've seen them like backing into spaces and just. In order to move my horse trailer, I need like a 40-point turn.
Good morning.
Oh.
How you doing? Hello. Great. Sorry, I'm down to
You got here on time.
I was, thank you.
You bet.
I owe you this one.
David, thank you
You
for
doing it?
following up on that.
Aren't they, isn't there like a,
Still working here?
I picked the clock.
Not today.
and there's a check on this side.
Basically,
Interesting.
it's on the rate of an increase, but I want.
Can everyone hear us?
Okay.
Yeah, okay. Yes. Okay, I can, yep.
Yeah.
Oh, there we go.
Compare. Division 3 on the coach there and input.
Yeah, I turned that.
Yeah. Basically.
All right, the lights are working.
Combination, that's what I. All right. Okay. All right. Thank you. If it's easier, I think it's easier just to chat. Yeah. Thank you.
Kristen, do we have a quorum?
Oh, sorry, I was trying to get the display.
I can wait if you need to.
Yes.
Hey, your water bottle looks like a cocktail shaker. I wish. And it's a lot. Okay, that's great.
If anyone can hear me, I'm only getting very spotty periodic reception.
We can hear you just fine.
Okay, good. Now I could hear that, but I couldn't hear anything before that for a while.
Yeah.
Thanks.
We're just taking count of whether we have the quorum or not, and then we'll get going.
Okay, thanks.
Between members.
Would be a quorum. 11?
Good enough.
The chair can rule us.
Just a quorum, in my opinion.
Okay, great.
Okay. Well, let's open this morning's MAC meeting. Good morning and welcome. It says at the top, introductions. I don't know you. I'm Lisa Britt-Solke-Stevens. I chair the MAC. I don't know if you know Kelly, our vice chair.
Nice to meet you both in person. I've been online before, but never come in person. I'm Carrie Collin. I'm working with Henry and the group as a consultant in the Medicaid program.
Oh, fabulous.
Nice to meet you.
Great. Nice to meet you.
A little background on me.
Oh, I'm a health economist and a professor at Dartmouth, and work in policy and in systems change and quality improvement.
Awesome. Very impressive. Welcome. All right. Henry, should we acknowledge our guests? We don't often have guests, but.
Rich Siegel from McLean Middleton Government Public Strategies. Yes, there is a guest.
I'm Nate Walker. I'm basically a member of the public, but I work professionally for Siemens, or a large vendor that supplies all the hospitals. And many of my hospitals have mentioned dish payments. I didn't know what they were. They come today. Don't think we'll talk about them. That's okay. I'll sit and educate myself on what's going on in the state.
All right, welcome. All right, moving right along, we have 4 rules on the consent agenda. I just want to make sure all of the members are comfortable with those items being on the consent agenda, in which case we can have a vote. Anybody in the chat, Kristen?
Nothing in the chat.
Okay. Any discussion on these items before we ask for a motion? Okay. Can we have a motion to approve the items on the consent agenda?
So moved.
Thank you, Kelly. May I have a second?
Hello?
This is Brooke. I'll second.
Thank you, Brooke. All in favor?
Aye.
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 Gary has
Any
his hand up.
opposed?
Gary has his hand up.
Lisa?
I don't know it's on my message in the chat, but I can't seem to change my husband's name to my name. And I'm not sure why, but just wanted to let you know I'm here.
Yep, I got it.
So noted.
Okay, so I believe that motion carried. So moving right along to the minutes of the January 13th meeting. Everybody should have gotten those from Kristen and had a chance to review. Were there any edits that were requested, Kristen?
Yeah, Teresa,
Mhm.
Gustafson, she did email me. I forgot to put her name in the attendance, so I will add those.
Sure.
To the,
Were there any other edits?
no one, besides that, no one emailed me.
Okay, great. Any of the other members?
Oh,
Hi, guys. It's
Uh,
Deo Dene from the
Dee,
Disability
yep.
Rights Center. My name's misspelled a couple times throughout. First in the roll call, and then on page 3 in the last section, the second bullet.
Sorry about that.
No problem. You can imagine it happens a lot.
I feel this to my core.
I'm so pleased that you reviewed the minutes that thoroughly though. Nice job.
Oh, yeah, of course.
Alright, so it sounds like we have 2 suggested amendments. They are not substantive. One is just to say that Teresa Gustafson was here in person, and the other is to correct spelling for Deo. Any other, because I think we could move the minutes with those changes so that we don't have to wait another meeting, right? Thank you, Olivia, for the affirmation. Okay, so may I have a motion to approve the minutes with those 2 edits?
So moved.
Thanks, Kelly.
You're welcome.
This is Brooke. I'll
May I have a
second.
second? Thank you. Who was that? I think that was Brooke. All in favor?
Aye.
Aye.
Joan has a question.
Aye.
Oh, Joan, I'm sorry. Ask your question.
Hi. Hi, everyone. It's just an editorial question on Henry suggested to start with what is available today. It's on future agenda items on provider relations training. So I'm not changing the minutes. I just want to find out where to find that information. Thank you.
Okay, well, we'll get there in a couple of agenda items. Let's just wrap up the vote on the minutes from the January meeting. Kristen, did you collect all of the
name?
the votes?
Yes.
Yes, okay, and the motion carries, I assume?
Yes.
I think after
Excellent.
Jones.
Mine was
Excellent, okay.
mine was just a point of clarification.
It was a point,
Thank you.
yeah.
I vote aye.
Yep.
Okay. All right. Kelly, membership updates.
So the membership committee met. It's really Brooke and myself.
Thank you for your service.
You're very welcome. We approved the nominations of D, new member representing disability rights. Karen is now going to be the alternate. Courtney Keene, new member representing Division of Public Health, and Allison Thorpe as the new alternate for Mike Arbach. Do we need to vote on that or
On Mike's alternate,
all of them?
we don't have to vote on Courtney Keene, but I think the other ones we do.
Okay.
Do we do them individually or can we do them like, well, we probably have to do them individually.
I think you could do this, you could do them together. They're all yeses,
Okay, excellent.
unless someone objects
Yeah,
to
that's
that.
the objection.
In that case, I will move Deo as our new primary member from DRC, Karen as our alternate from DRC, and Allison as the new alternate for the Dental Society. Do I have a second?
So moved.
Thank you. Any discussion? All in favor?
Sorry, I do. This is Deo Dene from DRC. I did want to just say that we're the Disability Rights Center - New Hampshire, and that should be written in there because there's DRCs in every state. So we do
Thank you.
actually need to denote the New Hampshire in there.
Thank you.
And for these meetings, I'm just going to be going by Deo Dene, or D is fine, but I don't go by Deo anymore. Unless you knew me as a
Thank you.
kindergartner.
Okay,
Thanks all.
thank you.
Your preference is D?
D.
D is fine, yep.
Thank you.
Hey, Lisa Britt, can I make a procedural motion once we go past this vote, or like a suggestion, not on this vote particularly, but just
Sure.
for the alternate process going forward?
Sure. So, did I get all in favor already?
Yes.
Yes.
Kristen, did the motion carry?
I think yes.
Excellent. Okay. Brooke, your suggestion.
I think as we're revisiting the bylaws in the future, I would like to make a suggestion to the group and to the subcommittee on that for those organizations that have an organizational seat that, I guess I would just put forward, I don't know that I would suggest that we don't need to vote on the alternate for an organizational seat, given that, it follows the organization, but I don't feel strongly about that. I just wonder if it would help us move things forward with a little bit less bureaucracy, but maybe that's necessary bureaucracy.
Yeah, we have to update bylaws for MAC, so we can take that up at that.
Yeah,
Yeah.
I'm not looking to resolve it today. I just put it forward as a discussion topic when the bylaws get reviewed.
Thank you.
Want me to introduce this next one? So I'll be providing an update on the BAC subcommittee, which has met about 3 times since our last MAC meeting. It's been a very helpful forum to start exploring our process for forming the Beneficiary Advisory Council. I think the key updates to share with this group is that we've developed recruitment materials, a flyer to share with potentially interested folks, and then also an application. We'll be sharing those, I think, probably later today or early tomorrow. We're just putting a couple of finishing touches on those. And we'll have the application available online as well as by paper or whatever format works for the applicant. The process we're envisioning is to just try and push out these materials as broadly as we can. We're going to have an informational session at the end of March for anyone who responds with interest, and then we can always schedule another one if we need to. And then the other more kind of procedural update from the subcommittee is that the subcommittee did recommend to have the BAC meet quarterly instead of twice a quarter, which is kind of the original proposition. Kelly and others, please feel free to add any feedback if I don't summarize accurately, but I think there were just concerns about capacity, making sure that we're making good use of people's time. And go ahead, Kelly.
I think it was also driven by the cadence of looking at the time frame within which the BAC needs to meet, and then the MAC needs to meet, but the MAC needs to, it's the cadence within which the information needs to flow and the amount of time that you need lead time to give people to be able to review that information. So the quarterly meeting just seems to be more appropriate to the members of the group to be able to get the ability to share that information. And you are right also, about the time commitment and standing it up.
So the requirement is that what comes up at the BAC has to be taken up by the MAC.
Correct.
And I think the bylaws could be constructed that, well, the regular cadence may be quarterly if they want to meet more regularly, because there's a reason that there would be nothing prohibited.
Yeah.
Yeah, and I'll say too, this is an exercise of kind of charting out what we think it'll look like, and then once we have a BAC recruited, they may very well suggest a different approach. So I think the main ask in sharing this with the MAC today is when we distribute the finalized recruitment materials, we would love your support in sharing that with your networks. Are there any other additions from any BAC subcommittee members? Might be online today. Want to add in?
So hearing that, I do just want to say, thank you to Dr. Lotz, Marissa, to Dee, to Olivia and Kristen for the amount of time they spent helping in the frequency within which we're meeting to sort of move this along. Thank you, guys.
Lisa? Oh, you're on mute.
I actually do not have the time right now to be part of the subcommittee. But I'm assuming that the subcommittee will be reporting to the whole, the MCA, right? And giving us updates?
Are you asking about the subcommittee to plan the BAC or the BAC itself?
And to plan the BAC.
that's what's happening today, and then
Right.
continue to update along the way.
Yes, definitely, yeah.
Okay, that's all I
Just wanna
wanted
make sure.
you.
It'll probably be a standing item through
Yeah,
implementation at this point.
and then
Excellent.
forever, because we'll be talking about what's coming up at the BAC.
So Lisa, when we met last
go ahead.
week, we went over, what we were requesting to be shared with the BAC, with the MAC. Olivia was just a bit more articulate and on the ball than I felt I was, and so I asked her to give that update.
Great. I was just wanted to make sure it was every month that we will be getting an update. That's great. Thank you.
Any other questions, comments?
Thank you.
Thank you.
Okay, so we have several suggestions for agenda items in the future, including the medical eligibility assessment or the MEA. I don't understand the second bullet, workforce direct support.
Yeah, I think we actually were hoping, I think the first bullet, Dave and Henry, if you agree, we know kind of what the ask is there, but for the second two, I was interested in just hearing a little bit more about the MAC members' interest, just to make sure we form a presentation that meets the need. So I know workforce direct support workers was raised in a prior meeting. I believe the request was just around like what information does the department have about workforce for this type of provider? Are there any kind of specific questions there or programs served by direct support workers that's of interest? And I'll say too, I listened to the recording for this one because I wasn't here for the entire meeting. So if I'm butchering it, please speak up.
Do you recall who made the suggestion?
I had that and I don't have it with me
Okay.
right now, but I can go back and check. I think so, but I'm not.
Who do you think it is? Can you speak up?
Lisa, you.
It wasn't me, I forget who it was, but I'm also interested in the whole workforce. So I'm not sure, I know for me, I would love to hear about how we're attracting workforce, Medicaid rates, just more about, the workforce issues. I know for myself as a parent, it is hard to find individuals to care for my son, do direct support. And how are we addressing that? How, do we have a plan? Do we have a strategic plan? I mean, we have to be able to compete with other states. Are we looking at our Medicaid rate? Are we looking at housing? Are we looking at, I don't know, but what's going on with what the agencies are doing or what the other agencies are doing, other providers, but it's definitely a huge issue. We're in a crisis. Thank you.
Thank you.
Then along that line, what might be helpful also is, and I'm really gonna defer to you all to decide whether you think it is, because you'll have the data points. But maybe if we look at enrolled providers by provider type, and maybe then people are gonna be interested to see it geographically, to see, if we're, and we can trend that over time, and people can see if their workforce situation is up or down. And I don't know that, well, maybe I do know.
That's an interesting cut. I know we have 30,000 plus people in the Medicaid program as providers, but by classifying them by category would be.
Yeah, I think it's tricky too, because I don't know if direct support workers are always enrolled
Correct.
providers.
I know,
Yeah,
I
so
know.
I was just thinking.
Yeah.
So we can look into that.
Correct.
Yeah, thank you. Are there any other points of feedback on that potential agenda item? That's helpful.
Maybe also just think about, like, I'm not sure that when Lisa's asking, people experienced challenges during COVID. But if we have the ability to look at even 5-year trend, so not year or quarterly, but you look back 5 years and you look back now, and you look at now, and then we can look going into the future. But I will, obviously, I do defer to just being a data geek, throwing out what I might be looking at.
Much appreciated. And then it sounded like Joan had some thoughts to share about the provider relations. Oh, sorry. Go ahead,
Lisa?
Look at, how many individuals, not, I'll be specific to the DD system, but I'm sure it's the same in the mental health system. How many individuals whose needs are not being met because there is no work, there are such challenges with workforce, and parents are doing the work or other family members are doing the work, unpaid or maybe even being compensated, but it's not exactly what the families want to be doing. So I don't know how you tease that data out, but that's something definitely I think we as a whole, as a system, should look at. Because we really are in a crisis. We're in a housing crisis for supportive housing, caregivers, and it's all, it's the elderly, it's the disabled, it's people with mental illness. And I don't know how you could tease out the different systems within the system. So that's my 2 cents. Thank you.
Thank you. Thank you very much for the input.
Anne?
Yeah, I just want to, I'm here today for CISNY because Marissa has to listen to Division 3. This is a timely conversation because they're talking about developmental services and funding today. I know at CSNI we're trying to get a handle on that because in the hearings, the Bureau had put in money for rate increases, at least for some of the programs that we provide within the system. That would hopefully be able to allow for a little bit of a higher wage within the context of that rate. But none of that as a priority was put into the governor's budget. So there's a bigger issue. I know for my agency alone, we have 60 DSP vacancies. Just one agency out of my entire region. We cover Merrimack County. So it's, all the money that's gone in, and we have a grant for employee retention. We're running ads. They're doing the best they can, but it's what we pay. It really comes down to what we pay. So it's a worthwhile thing to look at because we do have families that are not getting the services they need. Actually, some of the rollover money that's being rolled over is because we haven't been able to provide services. So it looks like it just wasn't spent. So there's some analysis to be done.
Sounds like the delta between authorized hours and provided hours will be very revealing.
Yep.
So,
Or to add to that, authorized to provided, or authorized or being provided by parents or someone in their family that was not the plan. I have a lot of families that are being paid. It's part of their program. But some of them are in their 70s. They don't want to be doing this. They'd like to go retire.
Exactly.
So 2 things, if I could. For people who can't be in 2 places at once, you can watch the entire hearing on YouTube. Division 3, put in Finance Division 3, New Hampshire, today's date, and you'll be able to watch the entire hearing. Secondly, I believe this week is the public hearing for, I think it's on the 12th. On the 12th.
The 12th.
It's your chance to do advocacy when they're taking testimony on the state budget. The state budget did not really provide for rate increases as it stands today. So I think So the advocacy community needs to speak up.
Yep, this is our
And This
opportunity.
is Ellen, and this is Ellen for the Governor's Commission on Disability. I want to really agree with Lisa and all of you that this is something that would be good to try and tease out the details if we can, because what I know is happening in our area is that a lot of people that were providing this service are now forced to work under the table because they make a lot more money doing the same job under the table than they do working for the agencies, and that's part of the lack of the numbers, and every place that I know of is down employees. So it would be a good thing for us to look into. Thank you. And definitely on the 12th, we need to speak up.
Yep. Where the brightest pink is possible.
Yeah.
I'm not really, I'm not sure where we exactly go from here, but I will say, you know, we do developmental service work as well. And I literally internally have identified the issue of our authorized to used units and sort of fussed about it, saying, hey, you need to watch out how much you're asking to be authorized and how much is getting used, because other people could you get that money into their budget. And so, but it's this is a really broad discussion, right? We're talking about the bench for direct care workers, all the way down to utilization and practice patterns of authorized services. And maybe it's a conversation we can have when we're planning the future meetings. But it seems like this particular agenda item isn't short for areas of focus.
Christine?
Hi, thank you. I don't know if this is the time to mention this or later on during the legislative proposal, but our workforce coalition worked with Senator Rosenwald on Senate Bill 244, and there was an across the board rate increase in that bill, and also a standalone rate increase for opioid treatment providers. The Senate Health and Human Services Committee voted last week to remove the across the board rate increases, and it reduced the opioid treatment provider rate increase to $2 million per year of the biennium. And I would also say that the pipeline development piece was taken out. So the area health education centers that work with kids to get them interested in roles like DSPs was also removed. So we're going to keep pushing on it. And I'll put our website in the chat, but if you want more information, please feel free to reach out to me. Thanks.
I feel like we have a really good sense now of, how we can go back and prepare this item for the future presentation. So if there's no other comments, I'd suggest moving on to the other bullet.
Thanks, Olivia. So the third bullet for future agenda items is provider relations training and advocacy. Joan, I know you had a comment about that.
Yes, I do have a comment about that. And it's interesting. It's relevant to all of the other conversations going on, because my key point was how can MAC advocate for the things that providers will need to be able to, adequately care for your population. But I am interested in provider relations training for, of course, I come from the dental world, and dental hygienists are not providers in this state. So there are advocacy issues that need to happen in order to develop the interprofessional programs that we need. But I wanted to know where we would locate the things that are already there, and then how do we advocate for advancement for providers as well.
And so you're interested in training for providers on how to do advocacy, is that right?
How to do advocacy, and also how to become a provider, and what are required for that provider to be able to comply with your,
What's enrollment, how to
Yeah.
enroll.
how to enroll,
Okay, great.
exactly.
We can
A
definitely share.
how-to, a very, a good how-to, a general how-to, so that we can push that out to our membership.
So we can definitely share the information available for, I'll say for providers who are eligible to enroll as a Medicaid provider. What's the process? So we can share that as follow-up to this meeting. And then if there are questions about that, let us know. I don't know that the department, provides any materials like related to advocacy training, of course, so.
So then I would suggest it could be just something out there for members to come back and share with the group. If you have any tools you use for teaching your provider group how to advocate, I'll certainly go back to CBHA and ask, and be happy to share that back. And if anybody else within their professional group has that, that would be nice to be able to share back with the whole group in general.
Thank you.
This is Ellen again. The SRC with Voc Rehab and the Governor's Commission on Disability used to provide an annual training that was open to everybody and anybody that was interested in legislative advocacy. And I don't think that's happened for quite a while, but I can talk to our director to see and go back perhaps and see what we may have in writing. But I know there was a 3-hour training every week that happened for years, and that might be a good thing to resurrect. Thank you.
Can you repeat who did that training?
I'm sorry, I'm having issues with the mute and unmute button. I'm sorry, what did you say?
Can you repeat who offered that training you just referenced?
It was with the SRC, which is a committee under Voc Rehab, and the Governor's Commission on Disability. And we used to collaborate on providing an annual legislative advocacy. Basically, it was a how to do legislative advocacy training for families, parents, anybody that was interested. And it was also open to state agencies. I think it's been years since it happened, but we may still have some of the information for that. It was about a 3-hour program that was offered once a year before the legislative session. And we had legislators participate in it, and people that were professional advocates and family members. And Lisa, I don't know if you remember any of those. I don't know if you ever attended those, but they were well attended and had some good results. So I will check with our director and see what we may have in the archives.
Yes, Ellen, I did attend the Governor's Commission, and I did, the Brain Injury Association, I was actually somebody who did the training for the Brain Injury Association with Ellen Edgerly. They do a really good job also. But
yes, they do it.
Yes.
Go ahead.
Lakes Region Community Services has been doing some training this weekend via Zoom. So I think there's some stuff going on. But how do we bring it out more broadly, right?
Yeah.
I think that's the question. Thanks.
Yeah.
Kristen, we have a comment in the chat.
Yeah, Isadora said that, she said, I'm fairly certain that it was BIA and GCD. They also participated.
Well, we're happy to push out anything anyone can send to us to take the opportunity.
Thank you.
Okay. Thank you, everybody. Looks like we're right on time to talk about the planning for the transition to the MAC on July 1st, Henry?
Sure, thank you. So the reason we're talking about BAC and Beneficiary Advisory Committee and the Medical Advisory Committee is because there was a federal rule requiring states to have both of these committees. In terms of the MAC, there were specific regulations about what had to be included. And these are some things that I want to get, not looking for a decision today, I want you to think about so that when we get to drafting bylaws that we have, the bylaws committee will have some of your thoughts going into it. So one of the requirements, which we currently do not have, is term limits. And it doesn't specify what the term limit length needs to be or not to be. But I think that we'll need to cover that, and in relationship to the point that Brooke Belanger mentioned earlier, in terms of also how we deal with our historic practice of having specific organizations that have I think we can deal with it. I'm just saying we need to think about how we deal with it in that context. There is an ability well, there's not ability to serve consecutive terms. The term limit just requires a period of at least a year to not beyond the committee from a term limit standpoint. The other consideration is we don't want standing up the MAC. We don't want everybody to term at the same time. So thinking about how we develop staggered terms so that there's not everybody leaving at the same time. I think part of that is surveying the individuals who want to participate. What's their tenure? They're thinking, do they have a retirement? Do they have other plans that would suggest a term of X years as opposed to X plus whatever? And then, so the new bylaws, I think we'll look at a couple states that have already put together bylaws for BAC and MAC, and so we'll look at our own bylaws, MCAC, and what another state has done. That's kind of what's coming forward. That's really for today. What we wanted to get on the table to have people think about these issues so that we can have a better discussion of them as they come up. And I think that's what I have. I'll take any questions.
I have one question. I know I should know this because I'm in all these conversations with you, but when we're talking about the term limits, we're talking about members, right?
Correct.
And then is there a difference with officers?
So I think that's that they're generally the way it works is you would have a term that would apply to you, and then so for example, if we picked a 4-year term, that and we picked say a 2-year term as an officer position, just hypothetically, is that you still would have to fit those 2 years within the 4 years.
Thank you. Lisa.
Lisa, do you have a comment? You're on mute.
Oh, sorry. Can you hear me now?
Yes.
Yes.
Okay. I've been on almost 18 years. So, and
Thank you.
Yeah, I feel like we should pause for a round of applause.
years, and I served when I was a state rep, when I was on HH. I mean, through it all, I've had strokes. I've had a lot of things going on in my life, and so I definitely believe we need new voices and more voices around the table. So I'm very excited about. Are we calling it BAC? BAC for short. I'm very excited about this new process. The one thing to keep in mind is having somebody there with some history. And again, it doesn't have to be me. I'm fine with stepping down. Somebody with history and somebody who, it took me a while. When I first got appointed in 2008, I remember for 2 years, I walked around like, I'm not sure if I understand everything. It took a while. So keep that in mind. I do think the term limits are important. And if someone could come back after, especially with the consumer advocates, it's hard to get consumer advocates, as you guys all know. So just keep that in mind. I definitely think 17 years is a long time, no question about it. Or I should say 18 years I've been on. So that's my 2 cents. Thank you.
Yeah, just to clarify, make sure everybody's understanding, I think the legislative intent and rulemaking of creating a BAC is to have meetings that are really focused on from the beneficiary's perspective, which is independent from MAC, where we deal with both that content and rules. So the idea is to give a forum for the quarterly meetings or more frequent if needed to hear the voice of people who are using services or representing people who like yourself. And then the MAC will deal with the more of the content on rules and waivers and the types of things that we more generally spend our time on here. So hopefully it makes it more rewarding to participate in either. And there's also the possibility you can participate on both. But there are requirements, I think, ultimately to get 75% of the BAC membership to be exclusive to that.
Yeah, I don't have the proportion in my mind, but we
Yeah.
can double check.
Yeah, pretty sure. So.
Doris?
Yeah, I just wanted to ask Henry if you could talk a little bit more about the process by which any changes to the bylaws should be made between now and July 1st.
Yeah, this is it's sort of like creating new organizations, right? We'll have to, we have a bylaws committee that is currently constituted under MCAC. I think we would use that committee, and if there were others who wanted to participate, because we always have room for people at the table, that we would use that committee along with the people who are working on BAC to come up with the bylaws for BAC and then the bylaws for MAC. And then once those entities start functioning, they can then have their own bylaws committee to adjust as necessary based on experience.
So Doris, I know you had raised some feedback about the subcommittee, or sorry, the bylaws in a prior subcommittee meeting, and Brooke had raised a suggestion. So some of you are conscripting yourselves into this effort by your interest in the topic.
And I think we have a starting point. I think we see a pretty good draft from another state that has adopted something previously. So we won't be starting with a white sheet of paper. We'll be starting with our own historic bylaws, what we think are good about that, and what another state has done to comply with the regulation.
I guess I would say if anybody wants to participate on the bylaws subcommittee, please let Kristen know. And when we convene, we'll be sure to include you.
Joan?
Yes. Hi, Henry. I really like what you said about the term limits and staggering them. But what came up for me as well was the word sustainability. So when we think about how we're going to stagger those terms and how we're going to, advocate for people to take our places is how do we sustain that? How do we help that transition from someone who's coming off and on your advisory committee?
So I think from my perspective, given our historic challenges of filling out MA, MCAC, that we not pick too short of a term limit, and that we try to get some participant feedback, like if you've been doing it for 18 years and you're willing to give it up 2, or you're willing to do it for 1, or just so that we get some feel of the existing membership, so that we can pick a term limit that doesn't cause us to be having to scramble because we don't have enough people to participate. So I don't know if that's helpful.
Yeah, I mean, we have to do our own advocacy work within our field and within our particular group that's a member of your council, and making sure that we're adequately doing that. Thanks, Henry.
Okay.
Doris, do you still have another question, or?
No, sorry.
No, it's okay.
There we go.
There you go. All right. Any other
comments on the MAC transition before we move on to the update? Hearing none?
Hi, everybody. So I got my my spreadsheet to Kristen about 5 minutes ago. So it's not here for you guys at this point in time, but she can send it out afterwards. It's featuring clickable links on the bills, which took me a little bit of time to get through, which is why I'm a little bit late.
Thank you.
And they should be the most up-to-date, meaning ones that have, if they've been amended, it should reflect the amendment versions. I would be checking those every month to make sure the link reflects the most current language of the bill. Also in the spreadsheet, you'll notice that I have yellow highlights on certain bills. That's from A, to direct me to which ones I want to pay attention to, and also the ones that, so you guys can follow along and see which ones I'm paying the most attention to at this point in time. And that should probably change every month given how some bills will be disposed of and other bills will become less important with time if they get amended or something like that. So without further ado, I'm going to start off with HB 583, and this is relative to state participation in Medicaid direct certification program for free and reduced price school meals. That has been laid on the table, so it's an annual bill or maybe biannual bill, however you want to look at it. And it's once again just not getting through the House Education Committee. We have HB 518, which is establishing its own state agency, Department of Children, Youth, and Families. There's a hearing on that scheduled for 3/18, which I think is next Tuesday, if I'm doing my math correctly. HB 392 is directing the dissolution of the Department of Health and Human Services, Office of Health Equity, and the Department of Environmental Services functions for civil rights and environmental justice. And the Governor's Commission on, and I have moved my table over, so it's a very long title for a bill. Governor's Commission on Diversity and Inclusion, and that has been retained in committee for now. HB 79, establishing a commission to study the privatization of the Liquor Commission, that has been ITL. HB 94 is relative to coverage of circumcision in the Medicaid state plan. That was OTP out of the policy committee, so we'll continue to follow that. I believe we'll be going to finance next. We have SB 34, which is relative to parental consent for student participation in the Medicaid school program. That was also OTP out of the policy committee. I want to work on an amendment for that one to clean up some problematic language, because at the moment it ties the consent to the ICD codes, new ICD codes, and that might create some problems and something we need to work on. So it's something on my list of things to reach out to further committees on. HB 524, it's repealing the New Hampshire Vaccine Association. Now I will note that my comments here say in committee because that's what's updated on the website, but I believe that passed the House.
Yes, it did.
Yeah, so my comments as to where it may be a little out of date.
But that I think only as a policy matter.
Correct, just the policy portion of it. HB 265, requiring that a public body's meetings minutes include start and end times of the meeting and the printed name and signature of the recording secretary. As OTPA, so off to pass as amended, is what that stands for. I haven't been able to go through and figure out what the amendment did, but it didn't look like it did a ton for the actual title of the bill. SB 119, this is Department requested legislation relative to Medicaid pharmaceutical services. So that passed the committee and is now in the Finance Committee in the Senate. And it may be getting some actions early as this week. We'll see. HB 691, prohibiting fluoridation of public water systems. That was ITL'd immediately after the hearing, which was a bit of a surprise. It was pretty strongly ITL'd, if I remember correctly. I think it was almost unanimous, or maybe one dissenting member. HB 732, to enhance consent and accountability in psychotropic drug prescriptions for children under Medicaid. That was heard last week, or maybe no, 2 weeks ago at this point, I believe. And David, I don't know if you have anything else to add to that one, or it's just is what it is.
No, I think the House committee passed it.
They did pass it. Okay, so it's a little out of date here. All right. So that'll go on to fiscal as well, then, because it does have a fiscal note attached to it. We have SB 120 relative to insurance coverage for biomarker testing. That was laid on the table, which I was surprised by. That looked like it had some legs at the policy committee. But SB 122 relative to financial eligibility for the Medicare Savings Program. That is also in the Finance Committee now, made it through the Policy Committee, and might see some action as early as this week. We're still keeping an eye out for that one. SB 123, which is relative to coverage for ear acupuncture as a substance abuse treatment under the Medicaid state plan. That also made it out of the Policy Committee and is at Finance as well. SB 244. This is relative to expanding access to primary healthcare services, increasing the number of direct healthcare providers, increasing Medicaid reimbursement rates, and making an appropriation therefore. That was amended, and I believe the title changed, and I don't think the Medicaid reimbursement rates are in there any longer, but I'd have to verify that. So that's slightly out of date. SB 134, relative to work requirements in the Medicaid program. That made it through the Policy Committee, is at the Finance portion, and you may see some action as early as this week. And SB 137, relative to hospital stays covered under the Medicaid state plan. And that also made it out of the Finance Committee and is in, out of the Policy Committee and is in Finance. And we're looking for possible action this week. With that, that's what I got from highlights. Happy to take any questions.
Great.
I think I have a
Is it
question.
okay if I ask a question? Yeah. For SB 244, you said expand access to primary care and direct care. What is in the bill if not the increased Medicaid reimbursement? We were just talking about this.
It looked like most of everything else stayed, but the Medicaid portion looked like it fell out. I needed a chance to do a full walkthrough of it when I was putting it together, but I did look for the Medicaid portion. I didn't see that immediately, but it looked pretty much the same as before. Go ahead.
Hi, this is Christine. I can explain what's in it if you want me to.
Oh, thank you. That'd be helpful.
Yeah. So there is a Medicaid rate increase in there for opioid treatment providers, but the across the board Medicaid rate increase was taken out. There's also funding in there for the New Hampshire Needs Caregivers program to train up to 500 LNAs. There's funding to expand the recruitment center contract that is with the Division of Public Health to broaden who can qualify for loan repayment. So it would be bachelor level staff in medically underserved areas. And then there's also funding in there for the residency program that is up and running at Coos County Family Health Services, so the only one north of Concord. And they are starting to recruit patients now and should begin the program on July 2026. So I think those are the big pieces. Oh, and there's also a mental health credential for early childhood and family mental health credential that ties back to a statute that passed a couple years ago.
Thank you.
Sure.
Okay. Any other questions or comments on the legislative update?
Oh, yeah. Great.
Thank you, Rob.
Thank you. All right, let's turn it over to Dave for the enrollment and eligibility updates.
Share my screen. And so this is essentially 2 months of updates. There it is. So January and February. So this is our general point in time. It is as of March 3rd. Similar levels to the last time we talked in January. Just over 180,000 total enrollment, just under 60,000 in Granite Advantage, and 125,000 in Standard. And this breaks that prior slide down into a view on a month-by-month basis from November of 23 to the present, and it breaks it down by the different eligibility groups. And just as a reminder, we use the November 23 as a starting point because that's after the unwind or during the unwind. That was where we saw our sort of lowest enrollment. And so you can see a tick up here for the Granted Advantage, and part of that is related to the open enrollment that happened in December on the commercial exchange. And what happens there is if someone applies for coverage on the exchange and it looks like they would meet the Medicaid enrollment eligibility standards, they get referred or transferred to the state. So we see more applications end of November and into December. And then in the children's population, you can sort of see a continual growth since January of last year, and that we think is related to the continuous coverage. And this is just a similar look, but it does it as of the first of the month. So eligibility always changes based off of when you look at it. First of the month, the numbers are a little lower, and towards the end of the month, the numbers are a little higher. Part of that is people who meet their spend down in the middle of the month then get added to the Medicaid enrollment totals at the end of the month.
Also, the numbers don't capture retroactive, right?
Yeah, and they don't capture retroactive coverage. And this is another stat we've been tracking and we presented at our House Budget Finance meeting. And it looks at, for the prior 12 months, voluntary reported closure reasons. So there are about 11,000, just over 11,000 closures that were closed at the recipient's request. Someone moved out of New Hampshire, death of the individual, or no longer wanted Medicaid eligibility.
Well, or a Granted Advantage that don't qualify, is that?
So these are voluntary. So if someone had a change in circumstances and a different income, they wouldn't be captured in this, but they're captured in like the redetermination dashboards. These are individuals that have like called the MCO and say, I moved out of New Hampshire. And there were probably some closed at recipient requests that maybe they called and asked to close because they know their income changes. And so this is the total snapshot for January. So there were 10,855 redeterminations. Just over 9,000 of those were ex parte or passively renewed. And there were 654 closures. And out of those 654 closures, 450 were failed to redetermine, which means they did not complete their renewal form.
How many?
450. But the total renewal rate was north of 90%. It's a similar look in February. Just from when the dashboards run, this is as of February 6th, so it doesn't have the final 2 days in it, so there's a little bit higher of a pending number than is probably what we would see if the dashboard reflected as of today. But there were 10,700 individuals up for redetermination, 8,880 completed a redetermination, and 11,000 closed. The large majority of the renewals were ex parte, where 8,127 were ex parte. And then this is a drill down into the children's population for January. And so there were just under 4,000 total redeterminations for January. 3,671 completed the READY, 230 closed.
Do you have the details on the failure to provide on that?
Yep, that one was the failed to READY was, it's right down here in this lower box. It was 178. Similar in February, just under 4,000 individual children up for redetermination, 3,052 completed, 552 closed. But the failed to READY rate was a bit higher, quite a bit higher at 454.
It's a high percentage of the cases closed that are closing for failure to provide.
Yeah.
And is it fair for me to process that some of the failure to provide, at least, well, it could be for both cohorts, could be related to the fact that they don't qualify, so they ignore it.
Yeah,
Yeah.
it certainly could be that. And we've been doing a call campaign, and I know part of the presentation just after this is on the E14 flexibilities that allow us to have a higher ex parte rate that are expiring. And so we're sort of, one, revamping the MCO communication campaign, our internal communication campaign, and some potential incentives to help try to at least lower the fail to ready rate and see. So, maybe it's because of income, but we would like to see the fail to ready rate lower and like an actual closure reason.
Otherwise, it's an unknown for us.
Yeah. And so this is the same look in the waiver population for January. Total waiver population, so there are 1,100, just over 1,100 individuals up for redetermination in January, 1,079 completed. There were 7 closures. And here, there was only 1 failed to read. The rest were for income or other reasons. And similar story for the February month. 1,037 individuals up for redetermination, 5 closures, 954 renewals. Look at the CFI population. There were 301 individuals up for redetermination in January, 3 closures, 288 completed the redetermination. And like the other populations, the large majority were passive, 266 were passively renewed. And in February for CFI, there were 307. There was only 1 closure. 287 completed the redetermination. Large majority were passive.
So in some prior months, we have heard some concerns that I think it's people who have been on CFI for a while are getting closed. And that would be in this number?
No.
So
okay,
this,
thank you.
yeah, that's a good reminder that this is the financial redetermination dashboard.
I would note with respect to the MEA process, just as sort of a preview to some subsequent discussion, is that individuals who appeal are able to remain open during their appeal, and that we do a process called bridging, which keeps people open until those appeals are heard. I think that's not necessarily the desirable approach to a long-term thing of doing so much bridging as we're doing, but keep in mind that coming out of the public health emergency, there were people who had not done ever maybe have done a redetermination or MEA, and it may be up to a minimum of 3 years and probably closer to 4 years between the last time of having to go through that.
Mm-hmm.
There's legislation on this topic. There's contract items for GNC. There's work to be done, but I think that's for another.
Mm-hmm.
Thanks, Henry. And this is the nursing facility view for January. It looks very similar to the CFI population. As a result, for 291 redeterminations, 1 closure, 256 completed their redetermination. And this is the look for nursing facilities in February. 279 individuals were up for redetermination, 1 closure, 245 completed. And then this is just a summary of what the redetermination results look like from August through January. So you can see the retained and sort of the peach flesh colored line here has been over 87% since August. And if you look back from August to December, of 23, it looks similar.
Can I ask a question?
Yep.
Remind me, what's the explanation for the delta between when you say there's 279, one closed, and 245 completed? So that's 246, but what's the delta?
Yep, so here, we'll just look at the nursing facility one for February. There were 33 pending at the end of the month.
Thank you.
And part of that is because this is as of February 26th, 2 days, but also for individuals in a waiver, they have tied to sort of the E14 authorities, they have an extra 60 days.
Mhm.
So if they were in the failed to read category where they hadn't provided their documentation, they'll show up as pending because we don't close them until they get the extra 60 days to provide the
Thank you.
documentation. And then I can give a quick update on our call campaign. So this is the updated results for January closures. So we had the MCOs call individuals that closed for failed to read or failure to provide information to be verified that had a closure in January. So there were 516 individuals on the MCO call lists. 155 were reached. Of those 155, 31% had already completed their redetermination. 21% were aware of the redetermination and the results and were working to complete it. And then 3% had completed their redetermination but were no longer eligible. And then the department also made calls to 120 individuals, and we were able to reach 36%. And so 35% had already completed the redetermination, were now open. 23% were aware that they needed to complete the redetermination and were working on it. None were unaware of the differences between a child's income for eligibility within a household and an adult. And then 28% had other insurance, 10 of which were children. And I think this sort of speaks a little bit, Kelly, to the question you had asked about that failed to read population. What do we know? What's going on with them? And it does, based on the people we were able to reach, some are certainly reopening, but there are others like the 12 we reached that had other insurance.
Thank you.
And this is a summary of sort of a holistic view when we started the campaign in August and what it looks like now through January 25. So there are just over 4,000 individuals on the call lists. 935 completed their redetermination and reopened, which is a 20% reopen rate. 11% of those reopenings were children, and 524 children and 411 adults. That 935. And then the last slide here today is just a summary of our ex parte rate, which in March was 77%. But I put this one at the end because I know the next discussion topic is the 14 flexibilities. So transitions into that, but I can stop and take any questions about the January, February results. Okay.
Thank you.
So we've talked a lot about our reference E14s, and these are CMS renewal processing flexibilities that were tied to the unwind. And it was to support states in returning to regular eligibility and enrollment processing, because all states, New Hampshire wasn't unique in that there were a large number of redeterminations that needed to be done throughout the unwind. And so CMS identified, the way I think about it is CMS identified certain characteristics of eligibility that are unlikely to change if you have access to certain data, and allowed states to use that process and that assumption to renew eligibility rather than requiring paper documentation from the individual. And so the two of the ones that we'll talk about here that New Hampshire used were related to income verification. But a major takeaway is that since November of 23, New Hampshire has had one of the highest ex parte rates in the nation. It's regularly over 70%. And I think if you look back before the pandemic, it was right around 50% or 40%. And we have a slide in here that shows the difference for March of what the ex parte rate would look like absent the E14 flexibilities. So the first flexibility New Hampshire utilized, or sorry, this is a summary of all the flexibilities. So there was the zero income strategy, 100% of the FPL strategy, and a reasonable compatibility strategy. And we'll get into a little bit more detail on each of these. So the zero income strategy allowed states to renew someone's Medicaid eligibility when they were up for redetermination, when the household had previously verified that there was zero income, and the state queries an external income data source and no information is returned. In that instance, CMS allowed the state to rely on the initial verified zero income, which in some cases could have been 3 or 4 years old, and renew that person. Whereas without the flexibility, the person would have to provide verification of their income. So if you fail the ex parte process, it doesn't mean you close. It just means you have 45 days to provide whatever documentation is needed to determine your eligibility.
But if you pass the ex parte, it doesn't mean you're eligible.
Right. And you are renewed with the caveat of if the information the state has relied on, please let us know and we will update your case status.
Important.
Yes. And the 100% FPL strategy, and so FPL is the federal poverty level limit. It's similar to the zero income strategy, but allowed states to renew Medicaid eligibility for individuals on an ex parte or passive basis when the household had previously verified income was at or below 100%, and the state queried external data sources and no information or no contradictory information was returned. And the reasonable compatibility strategy sort of wraps around both. But what it did was allowed states, when you're renewing someone's Medicaid eligibility, if you got information that was reasonably compatible, and for New Hampshire, it was a 20% threshold, which is similar to other states. And so the income was a little higher than the limit. You could say it was reasonably compatible to the standard, within the standard the person could renew. And CMS is no longer letting states use this strategy ever.
But remind me, did I see that bullet on the other two strategies? CMS is no longer allowing them to use it, or are we still talking about June?
No, we're still talking about June, probably. Yep.
So I think, probably not to jump ahead here, but in terms of we have a campaign that we're in process of planning, you're going to get to that over there.
Yep. And so this is it's a busy slide, but what it does is shows what the ex parte rate was for March on a case and individual basis, and then what the impact of removing the E14 authorities, so this is that middle section, would be, and what the new estimates for the ex parte rate would be at the bottom. And so the sort of takeaway summary is on a case-by-case level, the ex parte rate would decrease by about 28%, and on an individual level, it would decrease about 24%. So really looking at an ex parte rate of right around 50%, so down from the mid to high 70s.
That's why we're planning another type of campaign, and we got a new colored piece of paper.
Yeah.
Oh, great. More mail.
Lilac letter campaign.
For the spring. Heading into spring, it's, we're gonna do analytics to help inform where we particularly need to go with follow-up, and engage the MCOs if they can try to provide some of that work.
Yeah. So we're going to be able to look at on a monthly basis people who are up for redetermination, and essentially it's 2 months down the line. Everyone within that month will get a lilac letter informing them that there were flexibilities that allowed us to have a higher or to streamline eligibility processing, and that it's really important to look out for yellow colored mail, which is your redetermination application. And to renew you get a piece of yellow mail, you have to open it and complete it, return it to the department to be able to renew and redetermine your Medicaid eligibility. And it also provides the link to be able to do it on New Hampshire Easy. And for those that have elected to go green, they'll just be getting it through their New Hampshire Easy account.
Just for our eligibility workers, what this, I think, if you take March as a representative month, means they're effectively getting 3 more months worth of work. To do.
Yeah. Yeah.
So you're gonna go on a hiring spree for that?
Unfortunately, we can't hire. We're in a hiring freeze. It's one of our departments that has the highest vacancy.
As Henry alluded to, also working with the MCOs and providing lists of individuals that didn't go passive and trying to rank them based off of utilization and acuity to really try and lower that fail to read rates.
I've got to head down to, I think between David and Olivia, you can cover the items that are under my name.
Yep.
Thanks, Henry.
Thank you.
So I can take any other questions on the E14 flexibilities, but those expire at the end of June. So July 1, redeterminations in July.
Thank you.
So let's move on to the chatter about Medicaid policy changes, both at the state and federal level. And I had proposed that this be added to the agenda. I think there's a lot of sturm and drang with the expected, $880 billion expected cut. And if the federal Congress has the flexibility to decide how to extract that $880 billion, but if Medicare is off the table, as we've been told, and there's only like a list of littles in addition to Medicaid on the table, how do they come up with that kind of money?
Deep dive.
Right, this is the one we presented to the House.
Oh, okay. Do you know the national Medicaid budget?
In total?
Yeah.
Not off the top of my head.
I think it's less than 880 billion. At least it was in 2023 for the year that I looked it up and it was reported.
There was an article in the
Close
Times
to
this
the
morning,
number.
Remember Margot Snyder-Katz? She was up here for a minute. She's at the Times now, but she had a piece in their like morning newsletter that broke it down so that non-Medicaid world people could really understand the impact and the implications.
So we have a couple things that we can share on it today. Dave's pulling up like a high level summary. I'll also, there's a group called they're SHVS, State Health Value Strategies, I think something like that. They're out of Princeton, but they recently did a presentation that covers both the Medicaid changes and marketplace potential changes. So I'll include that with the follow up today's meeting, and then I'll pass it to Dave.
Sounds good. So these are there's sort of like 3 buckets of federal changes we're looking at that are talked about sort of most regularly. And the high level one is the FMAP reduction. So each Medicaid program has a federal matching rate. And sort of there are 2 aspects of this. For granted advantage or your expanded population for all states, it's 90% federal funds. And there's discussion at the federal level of to get to that $880 billion in savings, decreasing that 90% rate to some lower amount, 85%, 80%. And the big impact for a number of states, including New Hampshire, is that New Hampshire has a trigger law, which says if the federal matching rate for expanded Medicaid goes below 90%, the department needs to provide notice to fiscal within, I think, 48 hours, and then granted advantage sunsets after 6 months, unless there's legislative change in that 6-month period. The other one is lowering the minimum federal match. And so the minimum federal match is 50%, and that's New Hampshire's federal match rate. And this is determined on a state's per capita income. So poor states with a lower per capita income have a higher minimum federal match. But here it would be dropping it below the 50% floor. And so essentially just changing the calculation of how the feds will calculate that minimum federal match rate. There are also proposals or discussions about block grants, which is converting Medicaid to a per capita cap limit. So you would get essentially X number of dollars per Medicaid enrollee to cover, and if you wanted to go above that, states could through state dollars, but the federal dollars would stop. And then the other one we've heard a lot about too is a way it impacts, it restricts how states can use provider taxes. So I know someone mentioned DISH, which is the Medicaid enhancement tax, which is one of the provider taxes New Hampshire has, which is currently 5.4% of net patient service revenue. Lots and lots of states have this. I think last time we looked, there was like 34 or 35 states that had at least one provider tax that was over 5.5%. And what states do is they use the provider tax to generate dollars to match federal funds to pay service provider rates. And so one of the discussions at the federal level is capping what the cap at for provider taxes is. Right now it's 6%. There's been discussions of dropping it as low as 2.5%. So it really just impact the way the states can use those provider taxes.
But capping the provider tax caps the DISH.
Yeah, in New Hampshire's situation. But there's also separately a DISH. Each state has a DISH allotment, which is sort of a separate cap to how much can get paid out in DISH. And under the Affordable Care Act, there was a DISH reduction that went into effect and has been annually or continually delayed by Congress. And the House GOP presented their government funding plan this weekend, and the DISH delay is in there. But there wasn't really any other major takeaways on the Medicaid perspective from what the GOP released this weekend.
Questions, comments?
I think I see a hand raised. I think it might be Lisa. Oh, but maybe not.
Lisa?
Yes.
You're muted.
I'm mute, okay.
No, now you're good now.
Okay, take me a while to figure out this. I'm so used to using Zoom. Question about the cap. I personally, I don't know if anybody remembers this, but in 2011, there was a bill here in New Hampshire to pilot New Hampshire as a block grant. Does anybody remember this? And I testified against it. Anyway, long and behold, my feeling is that that it will be a block grant. That's just my thought. Has New Hampshire DHH looked at each one of these possibilities and come up with how I don't even know how you would plan for something like this, but thought or thrown around some ideas of how you will handle something like this with our state budget? Or are you just waiting to see how it all pans out? Just curious. Thank you.
I think it's a little bit of both, because right now we're kind of reading the tea leaves of what is possible, and then the impact really depends on what the specifics are in whatever passes at the federal level. But in terms of sort of informing our our delegation about what the potential impact could be, and other stakeholders at the federal level. We've certainly had discussions with them. And the National Association of Medicaid Directors has been really helpful in sharing resources for states to try and model what the impact of some of these changes could be. And there's a really helpful New Hampshire Fiscal Policy Institute piece on this as well, and that we help provide some data for their analysis on. But yeah, we also need to see exactly what they come up with too in terms of what gets passed. And we haven't seen any language on all of these. It's really just been at a discussion level.
Thank you. And as a parent, as a child who with a child who needs these services, I could start crying. It's very disheartening to constantly have to worry between the state budget, the federal budget about your child and loved one. And I don't know how we ever change the message of how important these programs are. I'm sorry, but it's very disheartening. Thank you.
Thank you.
Dee?
Hi, yeah, this is Dale Dene, from Disability Rights Center. First of all, I just want to acknowledge Lisa and what so many families who have loved ones using Medicaid right now are going through. I feel you are not alone, and I just want to thank you for all of your incredible advocacy over the decades. We are well served by advocates like you. On the state level, I appreciate this kind of analysis of the federal possibilities. I'm curious about the state, and I'm wondering, I'm a little disappointed Henry left, but I'm hoping someone might be able to speak a little bit more about the Medicaid changes being proposed here at the state level, and specifically trying to figure out the copay increases that have been discussed. Would these be applying to all enrollees, including those that are like in an HCBS waiver that is currently exempt from copays? Is this only going to affect folks who already pay copays? There just seems to be a real dearth of information for those of us trying to figure this stuff out. So if you could speak any more detail on that?
Yeah, sure. And maybe we can provide links. So Henry had also mentioned there's the House budget hearings that have been happening, and Medicaid has had two hearings before them too. So we could provide maybe links to those YouTube resources to anyone that wanted to hear them, because these were discussed there as well. But on the copays, so currently there's copays of $1 and $2 on pharmaceuticals, and I know that there are some exempt populations within there that sorry, I can't pull them off the top of my head right now, but it would be increasing the 1 to 2 to $4. And I think the 1 to 2 has been in effect for 25 or so years. It's been around for quite a while. And then there were also two pieces of the governor's budget around premiums, and one would be premiums for households with children that have an income of 255% or higher. And the 255% was, so when you look at children's Medicaid eligibility, 255% is the median nationwide. So New Hampshire goes up to 323%, which is significantly higher than the national median. So the premiums would start at what is the national median and go higher. And there are a couple caveats. This federal law prohibits cost sharing of premiums in excess of 5% of the household's income. And then there are also certain populations that would be exempt from premiums. And some of those policy details are still in process. But I know at the hearing there was questions around what populations could potentially be exempt, and a concern about not wanting premiums to get in the way of someone who's in an active diagnosis or treatment, say for cancer or the TB population or something like that. And so those policy discussions are happening, but
Okay, so to clarify, I'm sorry, this is all a little in the weeds for me, but to clarify, at this point, those that are currently exempt from copays, like folks on HCBS waivers, would remain exempt. There's no,
Yep.
Yeah.
that, those,
Yeah.
that
Yep.
has not
Yep.
changed.
That's
The
not changed.
increase, okay, and the increase in copays is gonna affect those who are already paying copays?
Yep. Correct.
Kristen, before we go to the next person, can you just check the chat? Because the chat's been there for a while, and I want to make sure we're not losing context of what somebody's trying to weigh in.
I've been checking, it's
Thanks.
just people saying, I'm
Thank
I'm
you.
dropping off, or
Thank
thank you, or that
Just a comment about collection of copays, because I was here when, well, I should say premiums, when we converted Healthy Kids to an M chip. And, we previously premiums have been collected by Healthy Kids Corp. For bringing it in-house, we would have had that, responsibility. And at least with the tools of the time, I think this was like 2012, it would have cost more to administer premium collection than it would bring in. And so, we were able to clearly demonstrate that eligible children never enrolled, and the only thing they still had to do was pay the premium. So it was a barrier to accessing coverage. And so I'm just wondering if any of those experiences of over a decade ago remain true today.
Good question. Do we want to hear Kathy's comment too, and then, or take that one first? I guess I'll just say, I mean, Dave, you can correct me, but there's no, firm price estimate of what we think it would cost to administer any of these changes. It's still too early, without the kind of parameters and details finalized. But I hear your point.
Kathy?
I'm sorry I came late to the party. I had another meeting. I'm not sure I understand the 5% thing. I am currently not paying a premium, but I do work. So, and I probably make right around the 15,000. I'm not even sure how much I make. But I don't quite understand the 250 thing. So can somebody put it in terms that I might understand?
Yeah, so the 255% is a percent of the federal poverty limit, and I think for a household of four, because we're talking about households with children, it's around $65,000 a year. So it would be above.
That's a lot of money.
And this is a proposal of the budget that's before the House, so it's not a final policy matter that's happened yet. So I think that's an important.
But I'm an individual. I'm not a family.
Yep. So the proposal is just for premiums for children in Medicaid. So it's that discrete population. So children's Medicaid in a household with income at 255% of the federal poverty limit. So if you're not a child, then it wouldn't, or you don't have kids, it wouldn't apply to.
Okay, but I read an article and it said something about individuals too. So I didn't really get it, but okay.
Yeah, I mean, there are pharmacy copays today that individuals might pay, Kathy, but there's also an eligibility criteria based on income there and other excluded groups.
Yeah.
So it is like a patchwork of different things that are being proposed. Each one has different inclusions and exclusions that apply based on income and program that you participate in.
I do think and wonder about people who would have a change in co-pays, and I understand that the copay, hasn't increased for a really long time. But people on fixed incomes of $700 a month, you might feel like it's okay for them to pay $4 a premium. I could find 100 of them for you in an hour who won't be able to pay it. And then they're gonna end up using much more expensive services. So I don't know how we get the opportunity to weigh on that.
Well, except that the pharmacist can't withhold the med if they can't pay the copay, they still have to dispense. So it's sort of this goofy, it's more aspirational in some ways, but they have to dispense the med even if there's.
But not everyone knows that.
They do now.
Yeah.
They will.
No, they should.
Sorry.
All right, anything else? Steve?
Yeah, I was just wondering, when you talk about children's, is that just the CHIP program, or is that Katie Beckett?
In the current proposal, it would just be the CHIP program.
Thank you.
Thank you.
Thank you so much. Let's move on to the department updates. We are right on time.
I will give the dental update. I am missing Dr. Finney, and I am not a dentist, so please take all of my updates with a grain of salt. But we're approaching 20,000 individual unique members served by the adult dental benefit, which is an exciting milestone, as we recently completed an amendment successfully presented to Governor and Council last month. We have 22 mobile dental events scheduled out through June 1st, potentially some other locations to be added. So far, there have been 151 mobile events with about 1,500 unique members served. So that continues to be a resource for us to kind of augment the access to services in this program as we develop the network. If you're interested in more details on where the mobile van is going, please feel free to reach out to me. And then I'm pulling up our network dashboard. Just give me 1 second. There's currently 191 unique providers at 132 locations in the adult dental network, and we continue to do on-site recruitment to strengthen that network. Any questions on the adult dental program?
Nice job. Thank you.
I'm going to hand it to Scott next for the DDU update.
Yes, good morning, everyone. And it looks like spring has sprung, so that's nice, finally. I just wanted to touch base. So as you can see, we had, as of the end of February, the reporting was we had a total of 36 HCCSD cases pending, with 4 of them over 90 days. We had a total of 287 adult cases, disability cases pending, with 42 of them over 90 days. Out of the 42 adult cases over 90 days, 15 were in the final stages of the medical review team. 2 were in a first request status. 14 cases were in a second request status, meaning that we had requested medical records from the providers once, and they didn't provide us, so we've done a second request. 1 case was currently needing a consultative exam, so it had been reviewed by the medical review team and determined that an exam was needed by one of our mental health providers. And then 10 exams were scheduled, so they were in the process of waiting for those reports to get back. As you can see, there was an upward momentum once again from the following month of January, where we had 60 adult cases over 90 days and moving forward. And then Kristen, if you just go to the next page. Since we didn't meet in January, I kind of wanted to give you guys like an end of the year on the roller coaster ride we've been on, and it really has been a roller coaster ride. So you see, these are total cases pending over 90 days, starting in January of 2024. And as you know, you guys were all on this journey with us where we kind of struggled with our contractor, getting them onboarded. They had some struggles in working with them. So, you know, we went up to the point where at one point we had 78 cases over 90 days, and we significantly gone down to, as of the end of February, we only had the 46. And that's total with adult and children's cases, just to be clear. So quite the comeback. We're right on track, and don't anticipate any struggles. With that being said, we don't know what's going to happen with these federal changes, you know, which could impact us receiving more applications. We don't know at this point. So that's really the update for this month, February, as well as kind of a roundabout of what happened this year. Any
Nice
questions?
job. Thank you very much, Scott. Nice job to your team.
It's amazing.
Thank you.
You will see increases in applications. You probably already are, because I know we're socializing within our provider group what the anticipated changes could be, and preparing people and working with people to make that transition. We have a lot of people on GA that if that changed, they would lose their coverage. And as long as we're not going to push them into a spend down status or something like that, we're working with them now to shift their aid category.
Excellent. That's, you know, and that's great. And don't wait until the last minute, you know, until the change happens. You know, try and persuade them. I know you can only do so much, but persuade them, act, you know, be proactive rather than reactive on it. It wouldn't shove them into a spend down. The way the system is built is that it will build the better program. So they could potentially, even though they're maybe approved for APTD and it would put them in a deductible, the system's built to keep them in granted advantage, whichever the better program is at this point. So definitely have them be proactive, so that we're not trying to be reactive at the last minute when things happen.
Excellent. Thank you. I'm glad to hear that. I did have a case that would have gone into a spend down, but it was a retirement income transition. So and they didn't, and the department reached out and said they're staying in GA. This is their scenario. It might have been a redate, but I will take that information back to the association to make sure that they understand that safety net's in place. Thank you.
Excellent. Thank you.
Carolyn, are you presenting the next update?
I am, yes. So our community reentry, this is I'm giving a brief update for community reentry. Our program went into place on January 1st. And we had 24 individuals that were identified for the reentry program. And there are currently 6 active participants, and there's 4 participants that started the program that are currently, we're calling them paused, but their Medicaid is suspended due to a change in their release date. 14 members were identified, but they're not currently in the program, but they're coming up because they haven't reached the 45 or 30-day benefit window. 11 of those participants are adult and 3 of them are youth. So again, the adult reentry demo, you have to be an incarcerated individual who's Medicaid eligible and have a substance use disorder or serious mental illness diagnosis. And they'll receive a limited Medicaid benefit pre-release prior to their release from incarceration. For youth, the reentry population, they must be Medicaid eligible and post-adjudication. And that coverage period is 30 days. And they also they receive EPSDT and certain other screening related services prior to their scheduled release. And we show a chart on the right-hand side to show the layout of the program so far.
So that's as of today. So we're moving along. It's going well so far. We've hit some barriers, bumps, lessons learned, but it's new to everyone, and Department of Corrections hasn't dealt with Medicaid yet. So we're forming a great relationship with them. So far, so good.
Excellent. Thank you, Carol.
Sure.
Who wants to pinch it for Henry?
I think for MCO contract 3.0, we continue to implement the new components of the contract. Our next amendment's expected July 2025. I don't think we have substantive updates for MAC on that today. And similarly for spending plan, we're actually waiting on a couple written updates from the Division of LTSS. I don't have the absolute latest on that. I think the last update I saw was June of last year, so I don't want to quote from that. But we'll provide some written bullets as follow-up. And then on the waivers, we continue to work on the 1915J personal care state plan amendment, including developing guidance for additional providers. I don't think we have any updates on the supportive housing SPA. And then our waiver renewals, we're working on an extension for the 1915B that authorizes the adult dental managed care program. And when we have our independent assessment completed for that, we'll be sharing it with the MAC in a future meeting. Do you have any updates on the 1115 waiver other than what you've already shared? It's kind of the main.
No, we got our 5-year extension back in July, and we're in the 5-year demo period.
Great. And then I know Jordan's on if you want to share anything on Medicaid to schools.
Sure, yeah, also not much of a big update there, but we did just finish scoring that RFP, and that should be finalized this week, and then we will move into the contracting process. So we are making good progress there, and it's exciting to have finally selected a vendor.
Thank you. In the last meeting, they requested we add electronic visit verification as an item to department updates. So I'm going to provide some information there. In January, we processed about 47,000 visits. So we are seeing a modest month-over-month increase on visits captured by the EVV system. Active providers monthly remains around the mid-40s. So that has been leveling off in the recent months. There are 2,860 2,400 active workers in the system as of January. We're also seeing month-over-month decreases in the tickets and call center inquiries, which is encouraging, but we are also seeing leveling off on claims submitted, which is not surprising because there are some claims payment issues with the EVV system that we're working through with the project team. So we're hoping to get those resolved in the coming months and see claim submissions come up in line with the visits captured. Are there any questions on EVV? And then I know we have HEE 805 on the agenda next.
This is Kara. I can speak to that.
Oh,
The committee last met on December 2nd. I did receive an update from Brian. The committee had some questions and also requested some information from the department. He let me know that they had not had a chance to work on that yet. And I don't have any other update. I don't know if Brian's on the call and has anything or if anyone has any other information. The committee will meet once we have the department's response.
I am on the call. That is a succinct way of putting it. We had some legislative priorities come up, so we weren't able to work on it.
Okay. Thank you, Brian.
Okay. We're including just informationally status on rules of interest. And I think that is the last presentation item.
Excellent. One other thing on the informational links. So we have the roadmap. There was an update that was recently released last week. So that link should take you to that. And then on the Medicaid budget pieces, and we can send out the presentations as well. But the Department of Administrative Services, we included a link there, and that has the whole state budget, but it also has the Medicaid budget, and it has the presentation materials that have been provided to the House Budget Committee, or at least I'm told that they will be posted there, if they are not already there. And then, of course, the SPA's public notices are, we have the link there, but there's nothing.
I think that brings us to the end of the agenda. Are there any other items before we ask for a motion to adjourn? Anything in the chat, Kristen? All right, we have a motion.
So moved.
Second.
Thank you. All in favor?
Aye.
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 Thanks, everyone.
Have a great day.
Thank you, guys.
Hi, friend. You were hoping to come here today to learn something about this.
Good.
Okay.